Good afternoon. We're going to move right into the novel influenza work group introduction. And Dr. Campos Outcult, if you can take the stage. Thanks.
All right, thank you very much. We're going to do a real brief presentation today on novel influenza work group and our deliberations. I'd like to give thanks to everybody who served on the work group. Here's the list of the work group members. And here's a list of the CDC technical staff. I'd like to give Sonia Olson a particular thank you today because she's been a real trooper in this work group for several years now, in spite of being deployed to some of the world's roughest and toughest places, including West Africa to help fight Ebola and down on the Mexico-U.S. border in Nogales, Arizona. And she's called in to the work group meetings and kept things going and never missed a beat. So I really appreciate her efforts. So our progress to date, we were formed in February 2014. Our charge was very limited, which was to develop recommendations for use of influenza A H5N1 vaccine during inter-pandemic periods. We made a presentation at the October 2014 ACIP meeting, which unfortunately I had to miss. And again, once again, Sonia filled in very well for me there, and I really appreciate that. We had a vote planned for February 2015, but this was another casualty of the potential for bad weather that occurred in February of this year. So we moved the vote to June this meeting. And then there were some production delays at the manufacturing plant, and they have been delayed back even farther. This current schedule is for the vaccine to be produced in mid-2017. We just found this out within the past couple of weeks. So this is our agenda for today, which has been changed based on this changing manufacturer schedule. We're going to present the epidemiology today and give an update on that. We are not going to plan a vote for today, and we're going to put the work group into semi-hibernation until we get closer to the actually having a vaccine to make a recommendation about. And we'll reconstitute the work group, which can be done very quickly. And if nothing has changed, we'll come forward with recommendations as we would have today. If there's been changes of any kind, we'll incorporate those and bring those forward at the proper time. So I'll turn it over to Sonia.
Thanks, Doug. I'd really like to thank Doug for his leadership and guidance on this work group, and it's been a real pleasure to work with him. So as Doug mentioned, the post-licensure lot of the H5N1 vaccine is not going to be available for another 2 years. So we'll delay the vote on the vaccine recommendations and revisit when appropriate. So today I'm just going to provide an update on the global epidemiology of H5N1 in humans and birds, provide an update on the new H5 viruses found in birds in the US, and then present some data on the vaccine cross-reactivity to some of these viruses. So since 2003, the Eurasian origin H5N1 viruses have spread in animals to 65 countries. This slide shows the 2015 data. So in 2015, H5N1 viruses have been found in birds in 20 countries. They're listed on this slide. In red, the red birds on this slide represent wild birds, and in green are the domestic birds. In only 3 of these countries, China, Egypt, and Indonesia, has the virus also been confirmed in humans in this year, 2015. This slide shows the number of human infections of H5N1 virus by country between 2003 and 2015. Infections from each country are shown in a different color. Between November 2003 and May 1st, 2015, there have been 840 cases in humans reported from 16 countries, and these have been reported to the World Health Organization. These cases have resulted in 413 deaths, which is a mortality of 53%. You can see here in yellow at the end there are the recent cases, and there's a large upsurge in H5N1 cases in humans in Egypt. This upsurge is the highest number of cases reported by a country in a similar time period. In 2015, there have been 132 cases in humans in Egypt. H5N1 viruses are now circulating in all sectors of poultry production throughout Egypt, and this likely reflects changes in the economy and poultry industry. There are many small farmers that are raising poultry in a largely unmonitored and uncontrolled farming sector. Experts continue to monitor the virus, and the hemagglutinin gene continues to evolve. However, it's not thought that the recent upsurge in human cases is related to viral changes. Instead, the increase is likely because of an increase in persons exposed to infected poultry. I will say that in the last month, cases have been decreasing. There are fewer outbreaks in poultry, there's increased public health awareness, and there's probably some seasonal risk factors that aren't fully understood. Another recent event is the detection of highly pathogenic avian influenza viruses in the United States. And in response to detection of highly pathogenic avian influenza H5N2 virus among commercial flocks in Canada in early December 2014, the U.S. increased surveillance in wild birds along the U.S.-Canada border and in that Pacific flyway. 3 novel viruses have now been found in wild birds in the U.S. These are in both captive wild birds as well as poultry, which includes both commercial and backyard flocks. These viruses are H5N1, H5N8, and H5N2. And I just want to comment that the H5N1 virus is different from the Eurasian H5N1 virus that I was just talking about in Egypt. These 3 viruses in the U.S. Are highly pathogenic in chickens. They are reassortant viruses with the hemagglutinin gene from a Eurasian H5N8 virus, and they're designated a new clade, which is clade 2.3.4.4. And the neuraminidase gene is from a North American avian influenza. And the neuraminidase is different from strains causing illness and death in that I talked about earlier. This table shows the number of H5 detections in birds and poultry in the United States between December 14th, 2014 and June 9th, 2015. There have been 256 detections of H5 viruses in 21 states. USDA and states have mounted a very large response, responding quickly with quarantine, eradication with indemnity, monitoring, disinfecting, and testing to confirm virus-free premises. To date, over 47 million birds have been affected. This slide shows the geographic distribution of high-path detections by H5 subtype. This blue circle up in the Pacific Northwest is the location of the 3 H5N1 viruses detected in wild birds. And then you have H5N8 in orange color and H5N2 in red color. The majority of detections as a whole are concentrated in 2 migratory pathways, the Pacific and the Mississippi flyways. And USDA scientists believe that wild birds introduce the viruses into commercial poultry. Although no human cases have been, or no humans have been infected to date, the CDC is working with USDA and local and state health departments to monitor for illness in persons exposed to infected birds or contaminated surfaces. This figure shows the number of high-path avian influenza infected premises detected between December 10th, 2014 and June 11th, 2015. And the slide is really illustrative of 2 points. First, that the majority of outbreaks, or about 90%, were detected in commercial poultry and chicken egg layers. That's in the green color. And second, that outbreaks may have peaked as the number of detections have decreased in recent weeks. Given the changes in the epidemiology of H5N1 virus clades circulating globally, and then the detection of these new H5 viruses in birds and poultry in the United States, we wanted to see if the QPAN H5N1 vaccine sera cross-reacted with any of these viruses. There are no published data, but CDC was able to test a small number of sera from 2 vaccine studies, a GSK1 and a CDC1. And sera were tested against viruses by microneutralization assay, as this assay is considered more sensitive than the hemagglutinin inhibition assay. And these data, although not published currently, will be submitted for publication in the near future. This slide shows the percent fourfold or greater increase in microneutralization antibody titers. That's on the y-axis. In QPAN H5N1 vaccine sera when challenged against other H5N1 viruses, shown here on the x-axis. In other words, an individual had to achieve a titer of 40 or greater. These other viruses include recently circulating H5N1 viruses in humans. You can see that overall there was some cross-reactivity to viruses, but the response varied by clade. And I'll just point out here, I don't know if you can read that, but it's the 2010 Egypt virus, and the response was fairly strong. This slide shows the microneutralization antibody titers, again on the y-axis, in QPAN H5N1 vaccine sera when challenged against the 2 new H5 viruses circulating in poultry in the United States. This is the H5N8 and the H5N2 virus. So in blue color is the response in the pre-vaccination sera, and in the red is the post-vaccination sera. And you can see that against the response against the same virus, the Indonesia 2005 strain, the response was robust. In contrast, there was essentially no response to these other 2 viruses. And these are from the GSK vaccine study. These next slide are from the CDC vaccine study, and it's essentially the same graph. The only difference is that we have some additional time points where serum was tested. And again, you can see the response to the same virus. It's in the vaccine. The Indonesia 2005 was robust. In contrast, the H5N8 and H5N2, the response to those viruses was essentially none. H5 viruses are grouped into clades based on their phylogenetic characterization and sequence homology of the hemagglutinin gene. The hemagglutinin gene of H5N1 viruses evolves in nature, and it's evolved into many genetically and antigenetically distinguishable clades. The H5 viruses in birds in the United States are part of a newly designated clade, 2.3.4.4. This is shown here up at the top. And this phylogenetic tree shows the evolutionary distance between those viruses and other viruses, including the QPAN H5N1 vaccine virus shown down here towards the bottom of the graph. So in other words, they're evolutionarily distant, and thus perhaps not surprising that there was no cross-reactivity. So overall, we found that H5N1 vaccine, the QPAN vaccine, offered some level of cross-neutralizing antibody titers to H5N1 viruses from various clades. The response varied by clade and were generally lower than the homologous vaccine strain. However, the response was robust to the clade 2.2.1 Egypt virus. In contrast, the vaccine elicited no neutralizing antibodies to the new H5N8 and H5N2 viruses found in poultry in the United States. Additionally, where possible, evaluating cell-mediated cross-reactive immunity may also be helpful to understand the potential for vaccine to provide some level of cross-protection. So in summary, highly pathogenic avian influenza H5N1 viruses continue to circulate globally and cause illness and death in humans. The most recent upsurge in Egypt was the result of increased poultry infections combined with increased interactions between infected birds and humans. The H5 viruses in the US are different from the Eurasian H5N1 viruses and so far have not caused any illness in humans. QPAN H5N1 vaccine is cross-reactive with recently circulating Eurasian H5N1 viruses, but not with the viruses in US birds. CDC is developing a candidate vaccine virus specific to the H5 viruses in the US that could be used to make a vaccine if one were needed. And CDC and WHO will continue to monitor the global situation of avian influenza. So my last slide, I'd just like to acknowledge the members of our working group, appreciate their assistance throughout this last year and a half, and some key individuals from CDC who have been helpful to put together these slides. Thanks very much.
Are there any questions? Dr. Blunsha.
Thank you. Very nice overview. It seems surprising to me that there have been so many flocks infected in the U.S. over the past several months, and yet there have not been any instances of transmission to humans that we're aware of. What do you make of that, or do we have any ideas why that might be the case, or why it's different compared to Asia?
Yeah, that's a good question. We have been doing some monitoring, and there have been about 30 people who have been exposed, gotten a respiratory illness. These are in states, largely workers on farms, and this is of approximately 1,000 or 1,100 people, and all of those have tested negative to date. Why? I think that's a good question. I think it may be that the virus is not well adapted. I'm not sure we really know the answer to that.
Two quick questions here. The first, there are 3 separate H5 viruses circulating in birds in North America. And is the homology in the hemagglutinins identical or very similar?
It's very similar. I'm not sure if it's identical, but it's very similar.
And then the second question is just on the graph showing the indication that the current avian epidemic appears to be waning, but is there not expectation that it's going to be on the upswing come October? And the question really pertains to if anything's going to be done in terms of assuring poultry workers being vaccinated with appropriate seasonal influenza vaccine to lessen the risk of potential co-infection.
Right. So the current thinking is that it may be decreasing in birds and poultry in the United States, but I think the expectation, at least by USDA, is that it would likely increase again in the fall because there is a seasonal, pattern to these viruses that we've seen globally for the Eurasian H5N1. So I think that is expected. There are recommendations for response workers to be vaccinated. I think that you raise a good point. It is currently, they are being recommended to be vaccinated.
Is that for response workers or also for just, the concern is, I know in my state that a number of poultry workers tend to be people who fly under the radar, that may be undocumented, are high-risk individuals in terms of slipping through the cracks in terms of usual medical type of assessments and so on. I'm trying to be proactive here in terms of what could occur later on.
There are different groups of workers. There are the farm workers, which I think probably fall into that category, which is about 1,100. There are also USDA direct hires as well as contractors that are responding to the poultry cullings, and that's worth around 3,000, 4,000. Those people there are written recommendations from USDA for response workers, which include that latter category. I think that the former category is probably more what you're referring to. And of course, there are global or U.S. recommendations for everyone 6 months and older. I don't specifically know what states are doing in terms of outreach, but we could certainly find out.
Other comment? Yes, Dr. Willie.
Yeah, I'm just interested in the pattern here. knowing that it's in the central, I mean, there's some in the Mississippi Flyway, there's some in the Central Flyway and Pacific Flyway. We don't see any in the wintering grounds of those birds. Now, they're migrating north at this point in time. Is there any indication of why that's occurring now as they're getting to their summer nesting grounds?
So sorry, you're asking about a particular type of bird?
Well, they're wild birds. I'm assuming that some of these are in ducks, et cetera, that are going north. And I'm just wondering whether or not, why don't we see any of these infections in the wintering grounds, knowing that we were seeing our epidemics like just recently in the nesting grounds?
Yeah, I mean, that's a good question. I'm certainly not an expert in the animal side of things, but I do know that the viruses have a different prevalence in different species and affect them differently, and in some cause overt clinical illness and some don't. So whether this is a factor of if they're if they have a routine surveillance ongoing, or if they're only testing birds that die, may be a factor. But I'm not sure about these specific birds that you're asking about.
Yes, Dr. Sun.
Hi, you look for cross neutralization with the micronewt of the Q5, the H5N1 sera humans against the avian H5 strains, and you didn't find any. But you look with hemagglutination inhibition assay to see if there are any.
They did not. CDC did not use that assay. They just used microneutralization with the assumption that it's more sensitive. So if anything, they thought if they were going to find something, they thought they'd be more likely to find it with microneutralization. But they did not test by hemagglutination inhibition assay.
Any other questions or comment? And again, this is a work group that is laying low for the time being. Dr. Campos-Outcult is rotating off. And I think it's going to be dependent on when vaccine becomes available. I think the decision was that we did not want to make a recommendation, have an approved recommendation, and have no ability to provide vaccine for that. Okay. Thank you very much, Sonia. And if we can have Dr. Karen come on up for influenza.
Good afternoon, everybody. It's really my pleasure to introduce this session for the influenza work group. I'd first like to thank the many members of our work group. You've heard me say this before, but we meet every 2 weeks, rain or shine, and it's a tremendous amount of effort that people put in. And of course, I'd like to especially recognize our CDC lead, Lisa Grosskopf, who puts a tremendous amount of work into this endeavor. Since you heard from us in February of this year, we've deliberated on a few different issues. One which you'll hear about this afternoon, and also hear some of the preliminary grade analyses, is on a comparison of high dose versus standard dose inactivated influenza vaccine for people over 65 years of age. You'll also hear an update on the 2014-2015 vaccine effectiveness from the U.S. Influenza Vaccine Effectiveness Network. We heard some of these preliminary data in February, and you'll hear final analyses now. And then finally, there are some safety updates that we'll hear from the Vaccine Safety Data Link. So we'll begin with Dr. Flannery, who will give us a vaccine effectiveness update. Dr. Robertson from Sanofi will talk to us about the Fluzone intradermal quadrivalent flu vaccine. Tom Shimabukuro will give us the safety update. Lisa will talk to us both about the high dose update, and then we will have a vote. at the end of this on the proposed recommendations for the 2015-16 season. So with that, Brendan?
Okay, great. Good afternoon, everybody. Just a quick thank you. These data are provided by the U.S. Flu Vaccine Effectiveness, or Flu-V network, and also a thanks to our data manager, Jesse Clippard, who put the analyses together for these updates. Okay, so there is not a surveillance update or presentation from the surveillance group of the influenza division today, but just a quick reminder, this was an H3N2 season. These are the last 3 seasons shown with the color bars for the vaccine subtypes and type and subtype. H3N2 is shown in red. The right hand is this season, and predominance of H3N2 for the whole season, with some B activity, and shown in green here at the bottom towards the second half of the season. There was not as much B activity as in 12-13, the last H3N2 season. Other thing to note is that the 2009 pandemic H1N1 virus, shown in orange, that predominated last season in the middle, really it did not circulate at a high level at all this season. So we really have no additional data to provide you on H1N1. These are the 5 vaccine effectiveness VE network sites shown here with the principal investigators. Ed Belongia is a principal investigator of the site in Wisconsin and Marshfield. And then Alicia Fry, along with myself, are the investigators here at CDC, the focal points for the network. I presented the methods for the VE network before, so I'm just going to go through this quickly. The analysis includes outpatients enrolled from November 10th of last year until April 10th of this year, when influenza cases were identified at the 5 VE network sites. VEs estimated from the odds ratio comparing vaccination among the influenza positive case patients versus the influenza PCR negative patients as our comparison group. Vaccination status was determined as for the interim analyses, except that this analysis excludes partially vaccinated children. And the adjustments are the same as the presentation in February. There are a couple of differences in this presentation. This season, for the first time, we're able to estimate vaccine effectiveness for specific groups of H3N2 viruses classified by the relatedness of the HA gene. The hemagglutination inhibition, or HI, is normally used to characterize circulating influenza viruses as either vaccine-like or low reactors to vaccine as a measure of antigenic difference or drift. Most or more than 80% of the H3N2 viruses tested at CDC by HI were low reactors or antigenically drifted from the 14-15 vaccine component, the A Texas 50 2012 virus. In addition, many H3N2 viruses could not be characterized by HI due to changes in the properties of the virus. And as a result, CDC used genetic sequencing to characterize H3N2 viruses, and then we infer antigenic properties based on viruses that could be characterized by HI, so a subset. And several genetic groups of H3 viruses circulated at the same time during the season, which provided us the opportunity to compare the vaccine effectiveness by genetic group. And we do that the same way as a vaccine effectiveness overall. The cases are just restricted to a specific HA genetic group. So this was a banner year for the Flu-VE network. There were 9,700 and change patients enrolled, more than 3,700 in our children group, 6 months to 17 years, and then more than 1,200 in our older group, 65 and older. 24% of those enrolled were flu positive. The 76% that tested flu negative, again, our comparison group. Overall, 83% of the positives were influenza A. All of the influenza A in our network were H3N2. Among the 17% of the enrollees who tested positive for flu B, 85% were the B Yamagata lineage that was in both trivalent and quadrivalent vaccines. Only 15% was B Victoria that's in the quadrivalent vaccines. Vaccination overall for those enrolled was 53%, again, excluding partial vaccination. Inactivated vaccines were about half and half, quadrivalent and trivalent. Live attenuated vaccine accounted for 26% of the vaccines among our 2 to 17-year-old group, and then the high-dose trivalent vaccine accounted for about 9% of the vaccine doses in patients 65 and older. So this graph is just our enrollment by week. The light bars or gray bars in the background are flu negatives. The red bars are the H3N2 cases. The peak of enrollment for H3N2 cases, or peak of enrollment overall, occurred in December, weeks 50 through 52 of last year. Numbers of influenza B cases in green here, which you can just see at the bottom, were low throughout the season with just a slight increase in March. This table then shows the percentage vaccination among influenza positive and negative patients and adjusted VE estimates. Overall adjusted vaccine effectiveness against any influenza was 23%. It was statistically significant, but quite reduced compared to previous seasons. Vaccine effectiveness ranged from 10% and non-significant among the 18 to 49-year-olds to 36% and significant among patients 65 years and older. For patients of all ages combined, shown in this table, adjusted vaccine effectiveness for any influenza vaccination was 13% against H3N2. It is significant, but the estimate is much lower than what we have seen in previous seasons. It was similar to what we've seen in previous seasons for both the B Yamagata and the B Victoria lineage, 55% against B Yamagata, with pretty narrow confidence intervals, and 63% against B Victoria with a bit wider confidence intervals. And this is the same overall data, now just broken into age groups, and it shows the relatively similar vaccine effectiveness by age group for any influenza A and B. There's some variation, but the confidence intervals, as you can see, overlap. Influenza A, H3N2, where there seems to be some variation in point estimates, but again, the confidence intervals overlap. Of note here, these are quite large sample sizes and groups, and we have large confidence intervals mainly because the estimates are so low that the confidence interval around 0 is larger. For influenza B, we have large confidence intervals because there's not as many Bs. So the take-home message is similar estimates by age, some variation in point estimates, but we really don't have the ability to compare the ages and say there were differences by age group. And now I'm going to get into the genetic analysis a little bit, and there are some different terminology here. The low vaccine effectiveness that we saw against H3N2 was consistent with the predominance of one genetic group, which is shown here in orange. It was characterized by the HI assay as being a low reactor, antigenically drifted. The sequences that we have from viruses that were submitted from U.S. laboratories through the normal influenza surveillance are shown in the pie graph on the left, and there are about 2,000 of those viruses that were characterized or sequenced. The graph on the right is our VE network and specimens that were submitted this season. This is unusual for the VE network to have this number of specimens submitted. It's usually just a small subset for antigenic characterization. And again, this season was exceptional because antigenic characterization was challenging. And so the VE network submitted over 1,300, almost 1,400 H3N2 positive specimens from patients who were enrolled to get these distribution of genetic types. A smaller percentage of the viruses that were typed is shown here either in red or pink, belonged to two groups that are characterized as vaccine-like. They have related names or nomenclature. 3C.3 is a larger group, an earlier branch on the tree. 3C, 3B is one that appeared later and was found particularly at the site in Pittsburgh, Pennsylvania, for an unknown reason. only 3% of the sequences virus belonged to another group, 3C3A, which was also characterized, like the predominant group, as a low reactor to vaccine. Notably, it includes the A Switzerland virus that has been chosen for the 15-16 Northern Hemisphere vaccine and is also in the 2015 Southern Hemisphere vaccine. Of note, Group 2A in orange, the predominant group, and Group 3A in purple there, that small group, share antigenic properties. So it's hoped that the vaccine will protect against either a 3A or a 2A virus if those continue to circulate this season. I'm now going to show some of the estimates just with a graph for vaccine effectiveness by genetic group. The 13% here is for all of the viruses that were sequenced, so very similar to the overall, just because there were so many H3N2 viruses that were sequenced. For the 3C3B group, which was our vaccine-like group, we actually see a higher point estimate, 43%, and statistically significant effectiveness against that virus or genetic group, and very low effectiveness, near zero, for our predominant group, 3C2A. Okay. All right, and I'll conclude with an update by vaccine type. This is an update on some data that were presented in February. This includes all influenza, so vaccine effectiveness against all influenza for live attenuated vaccine by age group or inactivated vaccines combined, trivalent or quadrivalent by age group. About 50% of the inactivated vaccine was quadrivalent. 50% of all vaccine in this age group was quadrivalent, and about 30% was trivalent, the other 30% being live attenuated vaccine. The vaccine effectiveness estimates were very similar by age. The 2 to 8-year-old age group and 9 to 17-year-old age group had very similar to the overall adjusted vaccine effectiveness of 9% for live attenuated vaccine. It's not statistically significant, versus 31% for inactivated vaccine combined, and the confidence interval there is smaller. That's a significant estimate there. For adjusted vaccine effectiveness just against H3N2, which was presented in February, updated estimates are negative 8% for a live attenuated vaccine with a large confidence interval, negative 44 to 20%, and for live attenuated vaccine, and 17% non-significant for inactivated vaccines. This is the comparison by flu type and B lineage. Adjusted vaccine effectiveness estimates against H3N2 B or the B Yamagata lineage were similar for inactivated vaccine shown on the left, or live attenuated vaccine shown on the right in each one of the boxes here, with the sample size at the bottom and the percent vaccinated. For H3N2, VE was low for both vaccine types, and neither was statistically significant. Vaccine effectiveness against flu B and B Yamagata was higher for both inactivated vaccine and live attenuated vaccine. And finally, we are presenting for the first time estimate for vaccine effectiveness for high-dose vaccine. These are preliminary data. There'll be some additional analyses looking at especially prior vaccination. The estimates were very similar when we controlled for high-risk conditions. The comparison between high dose and standard dose vaccine shows that both of the estimates were reduced or low compared to previous seasons. This is against any influenza A and B, but we had very few influenza B cases in the high dose recipients. The overall estimate was 14% for high dose and not significant. And for standard dose, any standard dose vaccine, trivalent or quadrivalent, was 31%. It was very similar, 38%, if we just limit that to a trivalent standard dose vaccine for comparison. The VE against H3N2 was lower for both vaccine types and not significant. For high dose, it was the point estimate was 1% with very wide confidence intervals. For standard dose, it was 16% and was not significant. So there are several important limitations. Some estimates have wide confidence intervals due to small numbers. of patients in specific groups, such as the high-dose recipients among 65 and older, the live attenuated vaccine by age group, and for the less common genetic groups of H3N2 viruses. And also, as for all observational studies, there's a potential for confounding due to differences in patient characteristics among the vaccinated versus the unvaccinated, or by vaccine type. So in conclusion, reduced vaccine effectiveness observed this season is consistent with the predominance of antigenically drifted H3N2 viruses. H3N2 accounted for 83% of the flu-positive cases in the network. Most of these viruses belong to genetic groups that were low reactors to vaccine. We did see significant vaccine effectiveness against the less prevalent vaccine-like viruses, H3N2 viruses, and then against flu B. Vaccine against flu B, VE against flu B was also good. 66 to 67% is quite reasonable for comparisons with previous seasons for flu B, for both a live attenuated vaccine and inactivated vaccine in children and adolescents. And finally, we did not observe differences in vaccine effectiveness by vaccine type, either for live attenuated versus inactivated vaccine among children, or high dose versus standard dose inactivated vaccine among older patients. And with that, I'd just like to thank the many people and groups that contribute to the U.S. Flu V network. Thank you.
I think we can open up for questions at this point in time. And I think for this section, we'll, because all the topics are a little bit different, we'll take questions after each of the speakers. So. Appears to be no questions. Oh, who am I? Oh, Dr. Karen.
So actually, I have a question for you, Brendan, and a follow-up question perhaps for MedImmune. And first of all, thank you for this wonderful presentation, and it's really helpful to see all of these data. So thanks to all of the participants in the network. Brendan, can you remind me? I know that the efficacy against effectiveness against H3N2 was low for drifted strains when we looked at all, both IIV and LAIV, or you reported around 43% for 156 cases. Can you split out LAIV in that for the viruses that were like the ones in the vaccine, and do you have that effect, or are the numbers too small?
I didn't include the slide. There was a slide that was shared with the work group. We found that the estimate against the genetic groups that were vaccine-like for live attenuated vaccine and inactivated vaccine were both higher. So similar to what I showed for all age groups when we limited to children and adolescents and just look at that 3C, 3B group. Was that your question?
Yes,
but I didn't
that was really
include
my
the slide.
question.
They're not. Neither of the estimates is significant compared to the unvaccinated group. It's just that they're small sample sizes. So it's consistent with the same trend that we see for any vaccine, where live attenuated vaccine and inactivated vaccine seem to have better effectiveness against the vaccine-like virus than against the drifted viruses. But we just have small numbers of the vaccine-like virus in our children and adolescents.
Okay.
Yeah, Dr. Sun.
This is Wellington Sun from FDA. In the slide that you showed, where you showed the vaccine effectiveness by age group, and it seems like the 18 to 49-year-old have the lowest vaccine efficacy. Is it because most of those strains were unmatched strains, or does that explain the low efficacy in that middle age group?
Yeah, and this is slide 10 here. I guess I can go back. I don't have an explanation for this. It's not as simple as that there was a difference in the distribution by genetic group, that H3N2 group. These data are for, and slide, it should be the one before. Maybe I'm on the wrong side. Okay, my apologies. The pattern looks very similar when we look just at the H3N2s, but we didn't break it by the vaccine-like and non-vaccine-like group. So this is, excuse me, the H3N2 here is in the middle by age group. We did not break it into the vaccine-like group and the non-vaccine-like group, but that 18 to 49 group is one that even our early estimates were lower for that group. I don't know why.
Dr. Decker.
Ian Gamble from NACI in Canada. I just want to make sure I understand about the LAIV. There was the drifted virus, which caused decreased BE. The bees looked okay, I thought. Can we surmise that the reduced vaccine efficacy for LAIV that we saw was presented in October is now well behind us, or can you make any comment on that?
Right, and the only reduced effectiveness that we saw was against the H1N1 pandemic strain. We didn't have enough H3N2 last season to have an estimate for LAIV, and MedImmune actually presented data that suggested that the LAIV was, the effectiveness of LAIV last season was good against B. So these data are consistent with good effectiveness against B. They don't help us at all with more information about the H1N1, and the H3N2 wasn't very good for either vaccine this year with this much antigenic drift. So,
Dr. Decker.
You're asking an interesting set of questions from your data, but you're not getting robust answers back because of your sample size limitations. So is there hope that in the future you're going to be able to expand the population under surveillance?
I think that the real question for ACIP in the past has been how well the vaccine is working overall, so any vaccine type. There is more and more interest in breaking out vaccine type, and here we have for the first time high dose versus standard dose. And we're dependent on how much uptake there is of the different vaccines. So in the last several years, we've had estimates for LAIV. This is the first year that we'll have that we can present an estimate for high dose. As new vaccines are introduced, it's going to be very difficult for us to increase sample size and keep up with these vaccines. And I know that there's a lot of interest in that. There are not plans to expand the network with the objective of trying to get vaccine type-specific VE estimates, but we are increasing the numbers that are being enrolled to look at the type of estimates that we've presented in the past, so against what circulates by age group and some of the predominant vaccine types. So that's where we are.
Dr. Rubin. I misfired there. Anybody else? Any other questions? Yeah, Dr. Shukat.
I just want to make a comment because the question about expanding the surveillance, I think for those who've been on the committee for a while, it's really extraordinary how much data there is by age, by vaccine type, by serotype in June. And we actually saw a lot of data in January. And folks who've been following this, 10 years ago, we would get this kind of data overall 2 or 3 years after the season. So it's extremely helpful that you have this big a sample size now, enhanced for children and the elderly. And I think it's very useful for the committee to be able to reflect on it. It doesn't mean that the answers you get are going to be clear, clean, tight confidence intervals. But with a moderate to low efficacy product, it's not, you could have a very large sample size and not get clear confidence intervals.
Dr. Blonja.
Yeah, I would just add, it's an understatement to call this surveillance because this is a very resource-intensive activity that takes, a lot of people and resources to pull off every year, and it clearly is paying off in terms of data and utility. So it's been very valuable, but it goes far beyond sort of what most people think of as surveillance.
Okay, thank you very much. I guess we can move. Dr. Sawyer.
Well, I just want to jump in this conversation and say that pediatricians of the world, not to mention the young children of the world, are hanging on your every word about LAIV effectiveness. We had a preferential statement, now we don't have a preferential statement. Point estimate might even make you wonder whether it's now inferior for some reason. The confidence intervals are very wide, but I would hope there might be some opportunity to tighten those confidence intervals for that age group so that we can resolve the uncertainty pediatricians are facing this year in trying to decide which vaccine.
Dr. Baker.
Just a quickie to underscore Dr. Schuchat's comment. Most hospitals now are not doing viral cultures. You can't do this kind of work unless you have an isolate. They're doing PCR. And they tell you A, B at most. So I just want to underscore the type of data that we have this quickly and the surveillance. I mean, I would call it something else. Doubly enhanced surveillance network, something, is really incredible. But we're going to a molecular area, and in virology, if you don't have viable virus isolates, especially with influenza, you have little idea what.
Okay. Oh, we have a comment up the microphone.
Hi, Wayne Hashi, Protein Sciences. Just on the bright side of the season, as luck would have it, we conducted a clinical trial during the season in adults over 50. Those results became available to us just shy of 24 hours ago, so the results that I have are still very preliminary, but in the over 50 group, our attack rate was 50% less than the comparator. So whether it's having 3 times the amount of antigen or not having to deal with a egg attenuated strain, that we don't know, but it did appear that our vaccine was reasonably effective during this past flu season. Just one of the subgroups, those who were 75 years of age and older, attack rate in the comparator was 40%, whereas with Flublok it was 25%. So as we get more data, we'll be sharing it with the work group.
Thank you. Anything else? Okay, we can move along to Dr. Robertson.
Good afternoon. I want to thank you for this opportunity to provide you with some information around Sanofi Pasteur's newest influenza vaccine, Fluzone Intradermal Quadrivalent, which I will refer to as QIVID in my presentation. Back in 2010, Sanofi Pasteur first introduced the intradermal influenza vaccine to the US in a trivalent formulation. Today I'm here to discuss the quadrivalent formulation, which was licensed about 6 months ago in December. And just so there's no confusion, for the 2015-2016 season on, Fluzone Intradermal will only be available in a quadrivalent formulation, and doses will be available this upcoming season. So for those of you who might not be familiar with Fluzone Intradermal vaccine, I want to walk you through this image, which shows the innovative microinjection system that we use for Fluzone Intradermal Quadrivalent. So the microinjection system consists of a ready-to-use pre-filled syringe that does not require air purging and contains a 0.1 ml dose of vaccine. Probably the most salient feature of the microinjection system is the feature that you can hardly see, and that's the microneedle that's pre-attached to the syringe. This microneedle is 30 gauge in diameter and about 1.5 millimeters in length, which is about the width of a penny. And the length of this microneedle ensures that the vaccine gets deposited within the dermal layer of the skin of young adults, regardless of their age, gender, race, or body mass index. Another component of the microinjection system is the integrated needle shield that can be activated after vaccination, as shown in the inset. And this needle shield covers the microneedle and may help reduce the risk of injury to healthcare personnel. Now, years ago, Sanofi Pasteur did studies to show that the trivalent formulation of Fluzone intradermal vaccine induced immune responses that were comparable to the Fluzone vaccine that we inject intramuscularly. So building upon that experience, we embarked on a clinical development program that consisted of a phase 3 clinical trial. We refer to this trial as QID-01, and this was a randomized, double-blind, active control trial that was conducted in multiple centers across the US during the 2012-2013 influenza season. More than 3,300 adults, 18 through 64 years of age, participated in the trial, and they were randomly assigned to receive one of 3 study vaccines, either QIVID or either one of 2 trivalent intradermal controls. Now, all the study vaccines contain the same A strains, but they differ with respect to their B strain compositions as shown in the table. Each vaccine was formulated to contain 9 micrograms of hemagglutinin per strain per 0.1 ml dose, and each subject received their assigned vaccine on day 0 of the study. Now, this safety and immunogenicity study, we collected safety data as we typically do in our influenza vaccine clinical trials. We monitored for immediate reactions within 30 minutes after vaccination, solicited reactions within 7 days after vaccination, unsolicited adverse events within 28 days after vaccination, and serious adverse events within 6 months after vaccination. HAI responses were assessed by collecting specimens before and approximately 28 days after vaccination. We had about 2/3 of the trial population randomly selected to participate in the immunogenicity assessment. And the endpoints we looked at were post-vaccination GMTs, seroconversion rates, and seroprotection rates. I'll move on to discussing the results of the study. So I just want to take a moment to orient you to this and the next 2 slides. Within each triplet of bars, QIVID appears as the first bar, and the trivalent controls appear as the second and third bars. You can see that injection site pain was the most commonly reported injection site reaction among all vaccine groups. Vaccine rates of pain, pruritus, and erythema at the injection site were comparable across the 3 vaccine groups. Most of the reactions were grade 1 or 2 in intensity and self-limiting. A similar pattern was seen for the injection site reactions of swelling, induration, and ecchymosis, albeit at frequencies that were far lower than the reactions seen on the previous slide. Again, most of these reactions were grade 1 or 2 in intensity and self-limiting. Here we're looking at solicited systemic reactions. About 1/3 of participants in each vaccine group experienced myalgia, headache, or malaise. Fever was a rare occurrence in the study. Less than 1% of participants in each vaccine arm experienced that outcome. Rates of unsolicited adverse events and serious adverse events were comparable across the 3 vaccine groups. There was 1 death reported in the study, and this occurred in a 60-year-old man who had risk factors for coronary artery disease, who had a fatal myocardial infarction on day 177 of the 180-day safety follow-up period. At rates of about 20%, comparable proportions of quadrivalent and trivalent recipients experienced either a grade 2 or grade 3 solicited systemic reaction. Likewise, comparable proportions of QIV and trivalent recipients experienced a grade 3 solicited injection site reaction at 4 and 3.1% respectively. Now let's take a look at the immunogenicity results. So here we're looking at post-vaccination GMTs 28 days after vaccination. Quadrivalent appears in green, and the responses for the trivalent controls appear in orange and blue. You can see that responses following use of the quadrivalent formulation induced responses, GMT responses that were comparable to those seen for the trivalent controls for all 4 vaccine strains. These striped bars represent the B strain responses following use of the trivalent controls that did not contain those B strains. And you can see that the GMT responses were about half those seen for the quadrivalent formulation. Based on predefined criteria, QIVID induced immune responses that were non-inferior to the trivalent controls with respect to all 4 vaccine strains, and B strain responses that were superior to the trivalent controls that did not contain those corresponding B strains. In terms of seroconversion rates, again, the quadrivalent formulation induced seroconversion rates that were comparable to those seen following use of the trivalent controls for corresponding strains. And similar to what we saw with the GMT responses, the striped bars represent the seroconversion rates following use of the trivalent controls for the B strains that were not contained in those trivalent controls. You can see that those rates were about half those seen for the quadrivalent formulation. By seroconversion rates, the quadrivalent formulation met all non-inferiority and superiority endpoints. So in conclusion, Fluzone intradermal quadrivalent vaccine was as immunogenic and as safe as trivalent intradermal vaccine in a healthy adult population. And with inclusion of the second B strain, Fluzone intradermal quadrivalent vaccine reduces the risk of B strain mismatch and can help provide improved protection against influenza. Included in the deck are slides on important safety information that I encourage you to review. And with that, I will end, and I'll be happy to take any questions.
Are there any questions? Yeah, Dr. Zahn.
Thank you for the presentation. So can I ask you, intradermal versus IIV, the other parts of the immune response, so cellular mediated immunity or otherwise, is it a fundamentally exactly the similar response, different response? What information exists about that?
Yeah, unfortunately, as you're probably aware, trying to measure cell-mediated immunity has been a challenge. And unfortunately, we don't have an answer to that question, whether or not use of the intradermal vaccine might have another mechanism of action in terms of inducing an immune response. But it's a great thought.
Yes, Ms. Hayes?
Yes, Carol Hayes with the American College of Nurse Midwives. It's my understanding that this is the only FDA Category A flu vaccine. Is that correct?
Actually, that's not correct. This is a Category B.
Thank you.
Yep.
There are questions as to what the categories for FDA stand for?
Are you referring to the device?
No, I was just asking if if this was a Category A. For some reason, I was under the impression that it was a Category A, that there had been safety clinical trials in pregnant women proving safety in this vaccine.
I'm not aware of categorization by safety. Can you be more specific on what by Category A?
I believe this is for pregnancy.
Pregnancy category?
Okay.
Pregnancy that category. Thing that we used to refer all drugs to, but now we're not?
Yes, I see. Well, this is a Category B. And also, by the way, which I will mention briefly tomorrow, the pregnancy category is going to go away, and there's going to be a new way to approach labels on pregnancy.
Any other questions out there? Oh, Dr. Engold.
Sorry, could I just ask, did you say this was in the 2012-2013 flu season?
The trial was conducted during the 2012-2013 flu season.
I'm just curious why it took 2 years to get a result.
Well, that's how long it takes for us to run those clinical trials. Well, we shared the results earlier, but it took that long to license the product.
Thank you very much. And I think we move along to the influenza vaccine safety update with Dr. Shimabukuro.
Good afternoon. Today I'm going to give an end-of-season update for 2014-2015 influenza vaccine safety monitoring and also cover a recent VSD study. So I will cover Vaccine Adverse Event Reporting System, or VAERS surveillance, Vaccine Safety Data Link, or VSD rapid cycle analysis, and then give an update on a VSD study looking at trivalent inactivated influenza vaccine and spontaneous abortion. So this is a reference slide of abbreviations that I'll be using throughout the presentation. I know most of you are pretty familiar with these abbreviations. Moving on to VAERS surveillance. This is also a reference slide to remind you that VAERS is our spontaneous reporting system, which is co-administered by CDC and FDA. And the strengths and limitations of VAERS are those inherent to passive reporting systems in general. So for VAERS surveillance, we looked at U.S. influenza vaccine reports received through May 22, 2015, in individuals that were vaccinated from July 1st, 2014 through May 1st, 2015. Signs, symptoms, and diagnoses were coded using medical dictionary for regulatory activities terms. VAERS report and medical record review, if available, were conducted for all serious reports after IIV4, LAIV4, cell culture IIV, and recombinant influenza vaccine. All anaphylaxis reports in persons with a history of egg allergy, pregnancy reports for spontaneous abortion, stillbirth, congenital anomalies, and serious reports. And empirical Bayesian data mining was conducted by our colleagues in FDA. So this is a table showing U.S. reports to VAERS following IIV3, IIV4, LAIV4, and IIV3 high dose. The important statistic to focus on is the percents in the parentheses, not necessarily the raw numbers. You can see serious reports for all vaccines and vaccine types ranged from about 5 to 6%. Guillain-Barré syndrome reports for all vaccines and vaccine types did not exceed 1%, and anaphylaxis reports were rare. This is similar to data we've seen for previous seasons for these vaccines and vaccines types. There are no confirmed anaphylaxis reports with a history of documented egg allergy, and no data mining findings for GBS or anaphylaxis. This is a table with cell culture, IIV3, recombinant influenza vaccine, and intradermal vaccine. You can see the numbers are smaller, likely representing uptake, but overall, the results are similar to the results you saw for the other vaccines and vaccines types, although the percentages are a little more influenced by small numbers. There are no confirmed anaphylaxis reports with a history of documented egg allergy, and no data mining findings for GBS and anaphylaxis. So this is a table of pregnancy reports in VAERS following influenza vaccination. There were 85 total reports after IIV3 or IIV4. In most of these reports, vaccination occurred during the first or second trimester. In 27% of the reports, there was a non-pregnancy specific adverse event reported. That's an injection site reaction or another non-pregnancy specific event. And in 64%, there was no adverse event reported. That total combined is 91%, which were not pregnancy specific. For the 8 reports that were pregnancy specific outcomes, 6 were spontaneous abortion, there was 1 stillbirth, and 1 report of vaginal bleeding. We had 18 total reports after LAIV4. Just to remind you, LAIV is not recommended in pregnancy. Of those 18 reports, in 17 there was no adverse event reported, and there was 1 report of spontaneous abortion. So in summary, there's no new safety concerns detected for IIVs, LAIV4, cell culture IIV recombinant vaccine during the 2014-2015 influenza season. Surveillance for the 2015-2016 influenza season will include enhanced safety monitoring for quadrivalent vaccines, cell culture and recombinant vaccines, pregnancy reports, and reports in persons with a history of egg allergy. So moving on to VSD rapid cycle analysis for the past season. So VSD is a collaboration between CDC and 9 integrated healthcare plans, has data on over 9 million persons per year, and it links vaccination data to health outcome data. The Vaccine Safety Data Link is a large link database using electronic health records. It has numerator and denominator data. Some of the limitations are sample size may be inadequate for very rare events, and medically unattended health events are not captured. So these are the rapid cycle analysis outcomes for the past season: anaphylaxis, Bell's palsy, encephalitis, Guillain-Barré syndrome, seizures, and transverse myelitis. You also have the age groups, the risk window, and the control window for the self-controlled design. So just to remind you, we have two rapid cycle analysis design. One is self-controlled, which a person serves as their own control, and you're looking at cases in the risk window versus cases in the comparison window. The current versus historical is looking at a current group of patients compared to a historical comparison group of patients. In this particular slide, the comparison window is after the risk window, but it could also be before the risk window, depending on the outcome. These are a couple tables of doses administered for the specific vaccines. As you can see, in all ages, IIV3 really dominates with 3.4 million doses. And you have smaller numbers for IIV4, LAIV4, and high dose. And uptake of recombinant and intradermal is low. For the subset of dose 1 doses for children 6 to 23 months old, we have 73,000 IIV3 doses and 86,000 IIV4 doses. So moving on to signal detection and evaluation for two of our outcomes, Bell's palsy and encephalitis. So the current versus historical design signaled for Bell's palsy in patients 50 plus years old following IIV4 in October 2014. And this is an automated ICD-9 code-based analysis. However, after chart review of cases, it was determined to be a false signal. The current versus historical and self-controlled risk interval designs both signaled for encephalitis following IIV3 in December 2014. There was no significant clustering found within the 1 to 21 day risk window. And after chart review of cases, it was determined to be a false signal. Moving on to our next outcome, seizures. Self-controlled risk interval design signaled for seizures in children 6 to 23 months old following IIV3 in December 2014. The reason I have signals and quotation marks there is because this technically is not a signal. This association has been observed in previous influenza seasons, so is not a new safety concern. Again, there were just over 73,000 total IIV3 dose 1 doses administered, 5 events in the risk window, 1 event in the comparison window, a relative risk of 17.5, which was statistically significant. The self-controlled risk interval design had a non-statistically significant elevated relative risk for seizures in children 6 to 23 months old following IIV4. Just over 86,000 doses, dose 1 doses administered. There were 8 events in the risk window, 8 events in the comparison window. The relative risk was 3.5. Again, this was not statistically significant, but was approaching the critical value of the log likelihood ratio. So to evaluate this increased risk of seizures following IV3, we combined data for the 2014, 2015, and 2013-2014 influenza seasons. This was the same formulation for the 6 to 23-month-old age group. That gave us a total of 244,000 total IV3 dose 1 doses administered to this age group. You can see in this table you have the vaccine or vaccine combinations and the relative risk. So for IV3 plus or minus IV3 plus or minus other vaccines, which could include PCV13, the relative risk was 2.5 and was statistically significant. In the next row, we have IV3 plus PCV13. So these children got these two vaccines at the same healthcare visit, plus or minus other vaccines. We have a relative risk of 5.3, which is statistically significant. For IV3 plus or minus other vaccines, but not PCV13, and for IV3 given alone, the relative risk was not significant. This is showing the same data in a graph. On the y-axis here, you have the risk difference per 100,000 vaccinations, and then you have age in months going from 6 to 23 months. Focus in on the red line here, that's IV3 plus PCV13. And you can see that the risk is highest in the 12 to 23 month age group and peaks around 16 months of age with a risk difference of about 43 additional febrile seizures per 100,000 vaccinations with that specific combination of IV3 plus PCV13. If you remember back at the graphs we've shown previously, starting in 2010, 2011, this looks very similar, both in the shape and in the magnitude. So in summary, we detected signals for Bell's palsy and encephalitis, both ruled out for true signals after chart review of cases. We detected statistically significant elevated relative risk for seizures in children 6 to 23 months old following IV3, and a non-statistically significant elevated risk following IV4. Further assessment indicated the risk was highest when IV3 or IV4 was administered together with PCV13 and was highest in children 12 to 23 months old, as has been seen in previous seasons. I neglected to mention that although IV4 was not statistically significant, when we did plot that graph, the shape of the curve was very similar to IV4. So moving on now to an update on the Vaccine Safety Data Link study. This was led by Dr. Jim Donahue at the Marshfield Clinic, evaluating the risk of spontaneous abortion following administration of influenza vaccines containing H1N1 pandemic 09 and H3N2 viral antigens. So ACIP recommends seasonal influenza vaccination for women in all stages of pregnancy since 2004. Available data indicates IIV is safe during pregnancy. However, limited data exists on IIV safety in the first trimester of pregnancy. Uptake of influenza vaccine in pregnancy increased during the 2009-2010 pandemic influenza season and in subsequent influenza seasons. Spontaneous abortion is a relatively common outcome of pregnancy. SAB is the spontaneous loss of a fetus before the 20th week of pregnancy, and pregnancy losses after the 20th week are called stillbirths. SAB occurs in 15 to 20% of women who know they are pregnant. Most SABs occur during the first 7 weeks of pregnancy, and risk factors include advanced maternal age, smoking, obesity, autoimmune disease, and prior SAB. A previous case control study in the Vaccine Safety Data Link in 2005, 2006, and in 2006, 2007 did not find an association with SAB and IIV3. And a recent meta-analysis did not find an association between SAB and monovalent H1N1 vaccination. The results of these studies and the meta-analysis were not available when the current VSD-IAV3 SAB study was initiated, and the largest study in the meta-analysis involved adjuvanted influenza vaccines. Other studies of seasonal IAV3 in pregnancy and SAB have been reassuring. So for the study purpose of this current study, is using similar methods to the previous VSD study, that was with 2005 to 07 data, conduct a study to assess if IAV3 containing the influenza A H1N1 pandemic antigen was associated with SAB during the combined 2010, 2011, and 2011-2012 influenza seasons. The primary objective is to estimate the association of SAB with IAV3 in a 28-day risk window. And the IAV3 formulation was the same during both seasons and contained the influenza A H1N1 pandemic antigen. So this was a matched case control design with a 1-to-1 matching ratio. Cases were women with SAB from 5 to less than 20 weeks gestational age. Controls were women with live births or stillbirths greater than or equal to 20 weeks gestational age. SAB was identified using ICD-9 codes, confirmed through medical record abstraction, and adjudicated to confirm SAB and SAB date. Date of SAB was the reference date for each case control pair. And cases and controls were matched on age group, less than 30 or 30 plus, VSD site, and last menstrual period. You see the eligibility criteria there below. Vaccine exposure included receipt of IAV3 documented in the medical record. The risk window was 28 days before the reference date, although the investigators also examined risk windows beyond that 28 days. Conditional logistic regression was conducted and included the following covariates you see there. So for the preliminary results, in the final combined analysis, there were 485 matched pairs. The adjusted odds ratio was 2.0 with a 95% confidence interval of 1.1 to 3.6 for IAV3 receipt in the 1 to 28 days before SAB compared to unvaccinated women. There was no association in other risk windows. So post hoc analysis, looking at the 1 to 28 day window, was conducted using looking at a season-specific analysis. So in looking at the 2010-2011 season, the adjusted odds ratio was 3.7 with a 95% confidence interval of 1.4 to 9.4. And in the 2011-2012 season, the adjusted odds ratio was 1.4 and was not significant. Again, it was the same IV formulation in both seasons. So this is additional analysis, and focus in on the table. Much of the rest of the slide is for reference. This is going back and combining the data again. So this is combined data for the 2010, 2011, and 2011-2012 season. And what this table is showing is looking at women, whether they received a pandemic H1N1 containing vaccine in the previous season, and then received an H1N1 containing vaccine in the current season in the 1 to 28 days before the reference date. So a pandemic containing vaccine in the previous season could have been the monovalent vaccine or the trivalent vaccine with the H1N1 antigen, depending on the season. If that was yes, they had received a previous H1N1 containing vaccine, and yes, they were vaccinated in the current season, the adjusted odds ratio was 7.7, with a confidence interval 2.2 to 27.3. If women did not receive an H1N1 containing vaccine in the previous season and then were vaccinated in the current season, The adjusted odds ratio was 1.3 and was not statistically significant. So this study is subject to limitations. A finding of effects of prior H1N1 vaccination were post hoc secondary analysis. The study was not powered for the secondary analysis, and although some of the relative risks were high, the confidence intervals were very wide. This is an observational study and subject to possible biases and confounding. It is possible that vaccinated women who had an SAB were more likely to come to medical attention, and we are not able to include possible risks from influenza infection. There may be other unmeasured confounding as well. The results suggest an increased risk of SAB in some pregnant women in the 1 to 28 days after receiving IAV3 during the combined 2010, 2011, and 2011-2012 seasons. The risk was not increased in risk intervals more than 28 days after vaccination. The increased risk observed in 2010, there was an increased risk observed in 2010, 2011, but not in 2011, 2012 when disregarding prior season vaccination with an H1N1 containing vaccine. In both seasons, increased risk was seen in women who had also received an H1N1 containing vaccine the previous season, but not in women who did not receive an H1N1 containing vaccine in the previous season. So these findings are preliminary and inconsistent with prior research on IAV safety in pregnancy. That includes the prior VSD study and the meta-analysis that I'd previously described. However, these studies did not evaluate the effect of prior vaccination. So CDC plans to follow up on this finding for SAB following IAV3 with additional research in the VSD. Plan to replicate the study in more recent influenza seasons and assess the effect of prior vaccination with H1N1 containing vaccines as a primary objective. We'll also attempt to evaluate the risk of SAB from influenza infection. So to sum up my presentation, during the 2014-2015 influenza season, there are no new safety concerns detected for VAERS surveillance. There was an elevated relative risk detected in VSD rapid cycle analysis for seizures following IAV3 and IAV4 in children aged 6 to 23 months. This is highest when IAV was co-administered with PCV13 and highest in the 12 to 23 month age interval. And this is similar to findings from previous influenza seasons for IAV3. The VSD case control study of SAB following IAV3, the preliminary results of 2010, 2011, and 2011, 2012 seasons data show an increased risk of SAB following IAV3 among pregnant women in the 1 to 28 day risk window who had received an H1N1 containing vaccine the prior influenza season. These findings are inconsistent with prior studies looking at IAV3 and SAB, and follow-up studies are planned. I'd like to acknowledge the following individuals for their contributions to this presentation, and I'll be happy to answer questions.
Thank you. Let's open it up for any questions or comments. Dr. Raleigh.
So on this, on the last part, the pregnancy issue, so knowing that more than half first trimester miscarriages associated with chromosomal abnormality, and that dating is invariably complete nonsense. In fact, nobody can remember their last ultrasounds are dependent upon, especially first trimester ultrasounds are dependent upon the skill of the person doing them. So what do we think the mechanism of action would explain this finding?
I don't think we know the biologic mechanism for this finding. I mean, in general, vaccination does cause an inflammatory response, but I don't think we have, information on a specific biologic mechanism to explain these findings. But I mean, let me just say that mean, this is an observational study. It's a case control study. It's subject to the limitations that some of which you just mentioned right now. And the investigators have done a substantial amount of sub-analysis to try to get it at potential bias and confounding. In our planned follow-up study, we are going to conduct a study that we hope will address some of the limitations that I mentioned.
Dr. Karen.
Thank you, Tim. So, two follow-up questions. One is related to some of what Laura brought up. And the question I have is, I believe that one of the sub-analyses that was done, these, as described, were matched on LMP with all of the problems related to that. And I believe that there was a sub-analysis done looking at ultrasound-confirmed pregnancies in the cases, which were a subset. And I have seen some of those data, so I'm wondering, one, if the Marshfield investigators wanted to comment on that, or if you did, Tim. And the second question I had really had to do with where do we go from here and future studies. And in thinking about these kinds of studies and the kind of confounding there is, I'm wondering about the utility of case control studies versus cohort studies, because I think it's probably really difficult to match in the way that we might want to match. And obviously, cohort studies are bigger and more expensive. But if we think perhaps that there is a signal here that is, or something that is worth further evaluation, is that a better way to go?
So I'll address the first part of your question, then I think I'll let Dr. Donahue, who's here, fill in. There was a sub-analysis which restricted the cases to those cases with fetal cardiac activity, and the results of that were that the odds ratio were still elevated. We also looked, as I mentioned in the methods, the SABs were from 5 to less than 20 weeks. We also restricted that to 7 to less than 20 weeks, and we still had an elevated odds ratio. And if there, I see Dr. Jim Donahue in the back, if he wants to address any further sub-analysis or any details of those sub-analysis I just described.
Yeah, hi, Jim Donahue. So, right, we did a sub-analysis in which we restricted the study population to women who had an ultrasound where they detected a fetal heart activity. Or like the question on the abstraction form was, is this a viable pregnancy? And the instructions to the reviewers were to look for fetal cardiac activity. And so we restricted our population to that. And it's about 30% or so of the total cases with that. And as Tom mentioned, we were able to do or repeat or redo the analysis for the main effect model. We weren't able to do the analysis for effect modification because we didn't have the numbers to do that. But for the main effects model, the odds ratio actually increased in the situation. And with respect to the different study designs, there are some variations on case control that might help in terms of offering some ability to control for factors that are fixed in individuals, self-controlled. But as you mentioned, a cohort would be great, except that it tends to be large and expensive, and it would be subject to certain biases as well. And one of the biases that's a big concern is the cases that we don't see, the cases that miscarriages occur and don't come to medical attention. And there may be some association there between the ones we don't see and are they more likely not to be vaccinated. And of course, that any study we do that's in a medical setting like this is going to be subject to that kind of bias.
I have Dr. Decker, Dr. Gorman, Dr. Baker, and Ms. Hayes. So, Dr. Decker.
Thank you. With respect to the seizure study, what you found was that there's an elevated risk of seizure, a statistically significant elevated risk of seizure only in association with concomitant receipt a PCV13 and IIV. I'm wondering, have you looked at the data from the other direction? In other words, if the entry criterion for your study was not receipt of IIV, but rather receipt of PCV, so that your entire population had received PCV with or without another vaccine, which might or might not be IIV, do you find that IIV is an effect modifier for the risk of seizure associated with PCV receipt? Or is this purely a situation where because you were looking at IIV and some of them got PCV and that causes seizures, that therefore you had an association with IIV?
Well, this is rapid cycle analysis, so it's just a sequential monitoring during the flu season. And the particular methodology we're using was based on what we did during 2010-2011, where we're looking at IIV. We happen to have a PCV13 study or surveillance going on at the same time, so we were able to incorporate PCV13. So it's really looking at IIV3 as the primary, or IIV as the primary, and then other vaccines as well. But I mean, your point is well taken.
I'm just wondering if this is drunk driving after rum and Coke, where the Coke doesn't have a lot to do with it.
If I may, Frank DiStefano, Immunization Safety Office.
Frank.
I think the committee has seen some data related to this. It was presented by Jonathan Duffy probably a year ago or so. And we looked at several vaccines and kind of addressed this issue as well. It looked like in those analyses, the PCV vaccines did have an independent effect, which became stronger if they were concomitantly administered with IIV.
Thank you. Dr. Gorman.
So first an observation and then a question. As the CDC becomes more and more proficient and all-encompassing with their surveillance, the numbers that they surveil will be larger, and therefore smaller and smaller differences will become statistically significant, making the job for ACIP harder and harder. Congratulations. Now the question. In a previous presentation on the seizures as well as, and could be applied to the spontaneous abortions as well, there was a number needed to vaccinate to see that effect also presented. So while there is, you show us an odds ratio, how many people would have to be vaccinated in a pediatrician's office in the past has been presented as a data point before they were likely, their odds were 50% of seeing a seizure. And
I don't have that information, I'm sorry.
That information would be useful, again, as these numbers get larger. Are we talking about once a month, once a year, once every 10 years? If I remember the numbers correctly from the last time the PCV IV was presented, the average pediatrician would not see a seizure in their entire lifetime.
Which is very similar to our discussion years ago on MMRV. And the level is dramatically similar at about 1 case per 2,500. Dr. Baker.
Thank you, Dr. Tempe, but my question and comment have been addressed by others.
Ms. Hayes?
Yes, I'd like to ask about the Donahue study, and I'm curious if they stratified and controlled the data for when the vaccine was administered compared to when the loss occurred, because the loss in pregnancy after 14 weeks usually has different causes. So between 14 and 20 weeks, you would have different risk factors than you did between 0 and 14 weeks of gestational age.
Could you say that again?
Certainly. Did you stratify the data based on when the vaccine was administered and when the loss occurred? So like if you administer a vaccine in the first trimester and she miscarries in the first trimester, that's a completely different scenario than if you administered the vaccine in the second trimester and she miscarried in the second trimester.
I think I'm going to let Dr. Donahue address that question.
Yeah, sure. So we did not stratify because we had very few that were beyond the 13 weeks. The median gestational age for cases in our study was 7. And the peak was right around 7. And we'd had, I can't remember exact number how many that were beyond 13 weeks, but we didn't have enough to do stratified analysis.
Dr. Sawyer.
Well, until Dr. Decker's rum and coke question gets resolved, I have a question about the VIS statement for influenza vaccine. now that seizures is again on the table for consideration following influenza vaccine. Under moderate problems reported in the VIS, the advice is to tell your doctor if a child who's getting a flu vaccine has ever had a seizure. I'm not sure what we want to do with that information, because we do not counsel against that they should separate vaccines. We don't counsel to give antipyretic because they're not effective. And what is a physician supposed to do with that information? And it makes me concerned that it will drive people to either separate vaccines or give antibiotics.
That's really out of the realm of the Immunization Safety Office as far as what gets put on the VIS and the counseling for that the physician gives the parent.
I don't know if it's your hand up, Dr. Alt.
I was going to make, I represent ACOG on the flu group, and I was going to make some of the same points that had been made previously, so it was a half-hearted hand raise. But one of the things that got mentioned there briefly was that many of these women are getting vaccinated within days of a missed period in the cases group. And that's a time when a lot of women don't realize they're pregnant. And when this came up, we had a lot of women that were going in very early on and getting vaccinated, and that biases the study towards a low-risk group being in the controls and a high-risk group being in the subjects. I think that explains most of the findings of this study.
One additional question, and Dr. Baker, go ahead.
So just a quickie, I mean, lovely presentation and great data and great plans for more data. But what are the communications people at the CDC? This may be a rhetorical question. After this information goes out there and we're already struggling with immunizing pregnant women, we're not making a lot of progress with flu vaccine since the pandemic, just because of historical worry about things, and now we have this data with its limitation. So what's the bottom line about immunizing during the first trimester? What does one say, and maybe Dr. Schuchat wants to answer, to a woman in the first trimester?
The pre-ACIP review of this data suggested that there was not need to change the communication about influenza vaccination in pregnancy. This was a signal that was going to be discussed with the full meeting to determine whether the signal merited further study for validation or not. A lot of good comments have been made about concerns about the validity of the study, which I think will be fed back into the research plans, but the kinds of limitations that people had already raised suggested that it wasn't time to change the message about immunization against influenza in pregnancy. In terms of the communication around seizure on the VIS, we have periodically reviewed that and revisited it, relevant for influenza, for MMRV, and for PCV13. And so that will continue to be relooked at, because we do want to make sure that the information that now is consistent is communicated clearly for clinicians and consumers. But the particulars about the signal in the pregnancy complication wasn't viewed to be of the level of clarity to change the communication yet.
One additional question, and I think it might be a problem with small numbers, but did the monovalent H1 vaccine preceding a second H1 vaccine make any difference if it was monovalent followed by trivalent, or trivalent versus followed by trivalent? Was there something about that monovalent vaccine?
There was effect modification for both seasons. Receipt of a monovalent or of a trivalent was significant.
Other questions? If not, then I believe Dr. Grosskopf.
Good afternoon. So this is an update on the grade process. As Dr. Karen mentioned earlier in our session, the work group has had a number of discussions over the last several months regarding the use of high-dose influenza vaccine versus standard dose vaccine for older adults. This is a discussion that's actually still ongoing. However, we did want to give you an update on where things were in the process, and also, of course, we welcome comments from ACIP on how to proceed further. Before starting, I want to thank the very large community of people who have had substantial input into this project. My colleagues Leslie Sokolow and Sonia Olson, who the three of us worked together on doing the core grade activities, but also Immunization Safety Office colleagues, as well as folks from the Clinical Immunization Safety Assessment Network who were of great assistance in assessing some very complicated safety data. In particular, Buddy Creech, Kathy Edwards, Ken Schmader, and Chip Walter assisted in abstracting safety data while we were doing it so we could see if we were consisting things in an interpretable, consistent manner, and we appreciate that greatly. And also thanks always to the flu work group. So as background, high-dose inactivated influenza vaccine, which we'll abbreviate here as HDIIV, it's only available as Fluzone High Dose from Sanofi Pasteur, was approved in 2009. The basis for approval was superior immunogenicity compared with standard dose IIV or SDIIV for persons greater than or equal to 65 years of age. There was a large randomized controlled comparative trial that was conducted over the 2011, 12, and 12, 13 seasons, published in 2014 in the New England Journal of Medicine. It's Diaz-Granados et al. 2014, and we'll see that later, which demonstrated a 24.2% better relative efficacy of high dose versus standard dose IIV for the prevention of laboratory-confirmed influenza associated with a protocol-defined ILI among persons 65 years and older. Current ACIP recommendations state that either high-dose or standard dose inactivated influenza vaccine are appropriate options for persons of this age group. For this evaluation, the question assessed was, do the benefits and harms favor high-dose IIV versus standard dose IIV for adults 65 years of age and older, i.e., better efficacy in preventing the primary outcomes of interest, as well as at least a comparable safety profile? In framing the question, the population was adults 65 years of age and older, intervention, high-dose inactivated influenza vaccine, comparison group, standard dose influenza, inactivated influenza vaccine. Because we were comparing two vaccines head-to-head, we focused on head-to-head trials and abstracting data on each vaccine rather than placebo-controlled trials of one vaccine or another. With regard to outcomes, potential effectiveness and safety outcomes were generated by the influenza work group. Safety outcomes were further discussed with members of the CISA project for their input, and they were ultimately rated in terms of perceived importance to policy-making decisions using the 1 to 9 scale that most of us are familiar with now, with 7 to 9 being critical, 4 to 6 being important, and 1 to 3 being considered not important for policy-making decisions. This was a somewhat more complicated analysis than we did the last time with LAIV, largely due to our own fault, which is that we went after too many outcomes because there were a good number that were interesting and relevant. So given that and time limitations, I can't show every single forest plot. I do have multiple forest plots at the back of the presentation should anyone want to see anything in particular. We will show some of them. So I'm going to start with the efficacy analysis. This slide summarizes the critical and important efficacy outcomes that were generated, as well as the papers that speak to those bits of data. For critical outcomes, these focused largely on laboratory-confirmed influenza-related outcomes. For us, laboratory-confirmed influenza, or LCI, means that culture or PCR was used to confirm infection. The various outcomes include any LCI from any viral type or subtype, LCI-associated hospitalization, LCI-associated pneumonia, medically attended LCI or visits due to LCI, and LCI-associated emergency department visits. Important outcomes included some less specific things such as medically attended acute respiratory illness and any influenza-like illness without regard to any culture confirmation of the etiology. Reviewing the literature for potential sources of efficacy and effectiveness data, ultimately we found 5 randomized controlled trials and 1 observational study. Further reviewing them, we found 2 papers that spoke to the outcomes of interest. These are Diaz-Granados 2014, which we mentioned earlier, a very large study, over 30,000 folks enrolled, and Diaz-Granados 2013, which is probably best to describe it as the precursor of 2014. It's the study is a very similar design, was initiated during the 2009-2010 season and intended to be a multi-year study. But alas, the pandemic came about during 2009, which made it difficult to assess seasonal influenza vaccine VE. So that study was stopped, and a similar design started again, which became Diaz-Granados 2014. Of note, there was no information for a number of outcomes that were also considered either critical or important. Particularly with regard to critical, we have LCI-associated death. We were not able to find any studies that spoke to that in particular, as well as a number of important outcomes which mainly focus on the impact of influenza on independence and ability to maintain activities of daily living among the elderly. I'm going to start with some of the efficacy outcomes. We'll do the critical ones in this section. And the first critical outcome was any LCI, all viral types and subtypes. We've actually looked at this 2 different ways here. Both Diaz-Granados 13 and 14 reported lab-confirmed influenza outcomes. Because Diaz-Granados 2013 occurred at the start of pandemic, it might be argued that it's perhaps not fair to include it. A pandemic strain, by definition, you might anticipate that, of course, a seasonal vaccine would not cover it because it's relatively antigenically novel. We ran it both ways in this particular case. You see the top line includes both RCTs. We did not downgrade for any parameters. Overall evidence type is category 1 or high, with a risk difference of 0.82, 95% confidence interval of 0.71 to 0.95. When we removed Diaz-Granados 2013, those numbers actually stay the same. The risk difference changes very slightly. It's apparent why when we move to the next slide, which is the forest plot. If you look at the forest plot, you can see the assessment for the individual studies, and the weight of Diaz-Granados 2013 is quite lower. It's a smaller study, fewer overall events being reported, so that at least analyzed in this manner, the risk ratio and confidence interval are similar whether we have included Diaz-Granados 2013 or not. So for that, we have a significant difference favoring high-dose vaccine, which is not too surprising as the weight is driven largely by Diaz-Granados 2014, which has been reported, and where was the first documentation, published documentation that high dose is more effective than standard dose in this age group. We also had a number of other critical outcomes that I listed earlier, and these speak largely to events that are associated with severe illness when somebody gets the flu. Not just that they got the flu, but that they got sick enough to be hospitalized, go to the doctor, have an emergency department visit, or get pneumonia. So these were our other critical outcomes. Only data available are from Diaz-Granados 2014 here. They're reported in the supplementary material that was published with the New England Journal article. We did downgrade here for indirectness, and the reason for that was that the events are reported as any such event that occurred within a 30-day period after the illness, the lab-confirmed illness. And particularly for things like hospitalizations and emergency department visits, within this age group, we considered that it was possible that those diagnoses or those events were not necessarily related to influenza or the illness that was the index of that time period. We also downgraded for imprecision on the basis of confidence intervals being fairly wide and meeting criteria for that in 3 out of 4 cases. The only one we did not was medically attended lab-confirmed influenza. So we have for all of the other outcomes, hospitalization, pneumonia, ED visits, evidence type 3 or low. For medically attended or medical visits due to LCI, we have type 2 or moderate. In no case was the difference significant. And you can see that from the risk difference in the right-hand column. I'm going to move on to some safety outcomes now. And I'm actually going to discuss both the critical and the important in some detail here. For critical outcomes, these are listed on the left side of the slide, there were a total of 3: adverse event or AE causing study discontinuation and any related SAE. We also had immediate hypersensitivity or anaphylaxis, but that's kind of an interesting case, which we'll discuss a little bit in a few slides. We had more data sources this time for most outcomes. Review of the literature reviewed 7 RCTs, which supplied some degree of safety data. What they supplied varied a little bit. If you look at the important outcomes, particularly the ones towards the bottom of the slide, things like fever, myalgia, headache, malaise, more systemic symptoms following immunization, versus local swelling or induration or pain, those were largely reported by two studies, Couch 2007 and Falsey 2009. Falsey is regarded as the pivotal safety study for high-dose vaccine versus standard-dose vaccine. There was also these kinds of symptomatic AEs reported by Keitel 2006, although some of them are reported in a way that made abstracting the individual symptoms difficult. So this is something we're going to return to when we do this reassessment again in the near future, as soon as we get some more information there. So there are going to be three tables describing, actually four, describing our safety outcomes now, and I'll try to summarize them as neatly as I can. These are our critical safety outcomes: AE causing study discontinuation, any related SAE, and immediate hypersensitivity or anaphylaxis. In the second column, where it's N, you will see something different this time, which is that there are two numbers there. One is, the first one that's not in parentheses, is the number of studies that spoke to that particular outcome. And then, because in some cases there was a study that reported on that outcome but reported that there were no events in either group, it was 0 on high dose, 0 on standard dose, we can't calculate anything with that information. So even though there might have been 7 studies that reported, for example, in the case of any related SAE, only 3 actually contribute to the pooled relative risk. So we thought that was important to know. With regard to the first 2 on that list, we've downgraded only for imprecision in either case. Overall quality of evidence, evidence type is 2 or moderate. There was no significant difference between either AE causing study discontinuation or any related SAE between the 2 vaccine groups. Immediate hypersensitivity or anaphylaxis we've included here. Nobody reported any of those events happening. It wasn't mentioned. They also weren't listed on the list of solicited AEs or where a study did it, adverse events of special interest. We had a lot of discussion about this both within work group and with CISA folks. There was a general consensus that had those events occurred, they would have been reported. If we were to assume that that's the case, it's 0 in all cells. We can't calculate any of the parameters for evidence for risk difference or relative risk. So we're including this here because it wasn't mentioned, it wasn't reported. That may be as much as we can say, and it may be that we're able to get more information about that in the near future, possibly from investigators. Important safety outcomes. Okay, I'm going to divide these into 3 groups. We've got serious things, and then we've got symptomatic things. These are the more serious things. Any SAE without regard to relatedness, any death within 6 months, and any death within 30 days. As originally conceptualized, we did not stratify deaths by time, but as some of the papers did, we decided to present it this way. We did downgrade for any death within 6 months based on imprecise confidence interval, wide confidence interval. Any death within 30 days was an extremely wide confidence interval. We downgraded actually 2 steps for that. We did not downgrade for any SAE. Any SAE is, it's unfortunately a general kind of outcome, and we cannot confirm that those outcomes were due to flu, and more than likely than not in many trials, in most cases, they're not due to the intervention. But it is also one of the few interventions with which we can try to capture potentially bad events that may be associated. In this particular case, there were 7 studies that contributed to that, so it was one of the few things that we actually had that many studies speak to. That overall evidence type is 1 or high, evidence type for death within 6 months, moderate, evidence type for death within 30 days, low. In any condition there, for all 3 of these, there was no significant difference in the pooled relative risk between the 2 vaccines. More important outcomes, these are systemic type symptoms, fever, any grade fever counted. Myalgia, headache, and malaise or fatigue, we looked at moderate to severe symptoms, so grade 2 or higher. We did not see a significant difference for fever and myalgia of moderate or severe severity, and we downgraded only for imprecision, so we have type 2 moderate quality evidence there. There was a significant difference in moderate to severe headache and moderate to severe malaise or fatigue, both on the order of a relative risk of about 1.5. And we did not downgrade for any features there, and that's considered evidence type 1 or high quality evidence. as we've done it here. Each of these outcomes were spoken to by Falsey et al., which is the pivotal safety study that was mentioned earlier, as well as by Couch. Couch is a smaller study. I'll say anecdotally that we also looked at the grade 3 only outcomes for each of, or grade 3 only observations for each of these outcomes. We do have then begin to see a significant association for myalgia, and we see a slightly stronger association for the other two. But once we do that, Couch sort of falls out of the picture, and we're down to one study from one season. So those results aren't depicted here. There is a plot at the end of the presentation, should anyone want to see it. Last two of the important outcomes, local swelling or induration and local pain or tenderness, both moderate to severe. Yes, we saw a significant difference in local swelling or induration, moderate to severe grade. We did not downgrade for any parameters. Both studies spoke to this outcome. Local pain or tenderness, we did not see a significant difference. We downgraded for width of confidence interval, evidence quality type 2 or moderate. And I'm just going to show a few of the forest plots from some of the significant results, the things that were different, just so you can see that event counts for Couch 2007 in the plot are lower. That study is weighted less. When we restrict analysis for looking at just grade 3 events, Couch generally has 0 events in each cell, so that's why it falls out. It's not that the Couch didn't report it, it's just that the events didn't occur. So then we're looking at primarily a pooled relative risk, which is really a pool of one study, which is never as much fun. Then we have, similarly for malaise or fatigue, grade 2 or higher, significant difference, again, 1.5, and Couch did report some symptoms here as well. Local swelling or induration, pooled risk ratio of 1.6, also significant. This slide, I'm going to move back to critical outcomes now. Summarizing our critical outcome results, we have basically a difference that favors the high-dose vaccine for prevention of laboratory-confirmed influenza with high-quality evidence. We have really no difference and low to moderate quality evidence for the indices that the work group was very interested in that attempt to get at severe disease due to lab-confirmed influenza. And we have no information on deaths. For safety, we have no difference observed between the two groups for any related SAE, or that first line under safety should actually say AE, not SAE, causing study discontinuation. And we have overall moderate quality evidence. If we were to accept as our overall evidence quality, the quality that's assigned to the lowest quality that's assigned to a critical outcome, we would come away with overall low quality evidence for this particular assessment. There are, of course, a number of limitations to this analysis, including but not limited to. One is that the main source for efficacy outcomes really is a single study conducted over 2 seasons. It's good that it's 2 seasons, often that we're dealing with studies that are only 1 season. We all know how much flu varies from season to season in terms of VE. Also, reactogenicity of a vaccine may well vary from season to season, so it's not inconceivable that safety outcomes could be impacted as well by not having a lot of seasons represented. Data for a number of critical outcomes are not available, for example, LCI-associated deaths and anaphylaxis, or the data that are available are somewhat indirect. So that would be LCI-associated severe clinical outcomes. However, it could be argued that it would be potentially difficult to power an RCT for these outcomes, particularly when we're talking about deaths and anaphylaxis. Hospitalizations and the like may be difficult as well, possibly requiring something more like a large observational study. Some of the safety outcomes of interest are simply very uncommon. This is related to the last point. It can be difficult to power a study adequately detect differences for these things. And lastly, safety outcomes may not have been defined or interpreted during the course of the study similarly across studies. Things like fever were defined relatively uniformly, we found here. Swelling, not necessarily so we end up having to make some assumptions. I want to mention 2 other things that were not included in grade that are nonetheless very important and probably you've heard of. There's an additional study, this was the observational study that we came across when it was actually only just recently published when we were doing our literature search, Izuri et al. This was not included in grade, and I'll explain why. This is a retrospective cohort study of Medicare beneficiaries age 65 and older who received either high-dose IIV or standard-dose IIV during the 12-13 season. The primary outcome, and this is really the root of why we didn't include it, this in the secondary outcome, was receipt of a rapid influenza test followed by dispensing of oseltamivir, which they termed probable influenza infection. Secondary outcome was hospital or emergency department visit listing a Medicare billing code for influenza. And in this particular case, the Medicare, the billing code, the ICD-9 code actually that was used was fairly specific for flu. So among over 900,000 high-dose recipients and over 1.6 million standard dose recipients identified, high-dose inactivated influenza vaccine was 22% more effective in preventing either of these outcomes, and that was statistically significant. So this is important to know. We believe it really provides important support to the notion that the vaccine does prevent flu better in this age group. However, we felt that we could not include it in grade as it was felt not to address a critical or important outcome. We felt it would have been a bit of a stretch to call this lab-confirmed influenza, so we have not included it. As an observational study, it would have started out as type 3 evidence, which would already be low. We would likely have to downgrade it simply because of not being, at minimum, not being a direct outcome. The other thing I'll mention is VAERS, of course, is constantly looking at safety data, and there was a paper published by Morrow et al. Based on vaccine adverse event reporting system data for the 2010-11 season, which looked at events associated with high-dose vaccine. There were 606 reports in patients aged greater than or equal to 65 years. Only 8.2% of these events were judged serious events, which is reassuring. MEDRA terms were for ocular hyperemia and vomiting exceeded the data mining threshold during that period. 80% of these reports were non-serious, also reassuring. Clinical review of serious reports found a greater proportion of gastrointestinal events compared to IIV3 standard dose. During the first year after the US licensure of the trivalent high-dose vaccine, in summary, there were no new serious safety concerns identified in VAERS. Analyses suggested a clinically important imbalance between the reported and expected number of gastrointestinal events, though, after trivalent high-dose receipt. Following a little more on safety, between 2011 and 2015, this is something that's been discussed at ACIP at our safety updates in the past couple of seasons. There was disproportional reporting for the MEDRA term vomiting observed during the 12-13 season. Most of these, again, were non-serious and self-limited. There was disproportional reporting for the MEDRA term drug administered to patient of inappropriate age, not really an AE, more of an error. But that was the only other thing that was noticed during 12-13 and 13-14. In summary, no new safety concerns were identified in VAERS reporting for Fluzone high dose in monitoring from 2011 to 2015 following its initial season of use in 10-11. Now, that is what I have for this. As I mentioned, this is an ongoing discussion. Based on the evidence discussed with the work group does not think there's consensus at this time that a alternative policy language or a preferential language should be proposed, and this is something that we're going to continue evaluating as more data come out. We are aware of at least one other study that's currently being conducted in elderly nursing home patients, which won't have data available for at least another year, but this is something in a population that the work group is very interested in and obviously vulnerable to severe outcomes. So that's what I have. I'd be happy to take any questions.
Up at the microphone, please.
Thank you. David Greenberg, Santa Fe Pasture. Thank you, Lisa, for a fine presentation. We just wanted to note that we look forward to the ongoing discussions. We know you're in the middle of the analysis, and we've been doing a lot more analysis of the data that is available from the seminal trial. I agree with your conclusion that the data from the 2009-10 season doesn't make much sense to include in grades since the strain was neither in the high dose or the standard dose vaccine. With regard to the primary study, I'll just note that the 24.2% relative efficacy or reduction of disease that you noted early in your presentation was the primary endpoint of the study. it appears, from what I can tell in your presentation, that you used the relative efficacy for any respiratory illness that's laboratory confirmed, and
That's correct.
And that was a less sensitive or less severe case, in the sense that respiratory illness of that study was defined as any one respiratory symptom. Sneezing alone would qualify for a respiratory infection, whereas the protocol-defined ILI was, as you would expect, at least one systemic symptom and one respiratory symptom. As I say, we are doing many more analyses, and there are publications that are coming out this summer and fall having to do with some of those secondary analyses on effect of the vaccine in people with comorbidities, with more severe disease, and others. And we have looked at cost effectiveness. So we look forward to sharing those data with the work group, whether it's a 24% relative efficacy or a 22% as found in the CDC FDA CMS study, that is a Reddit paper. There's a substantial cost savings because of the reduced hospitalizations that are influenza related. So I think it is an important or critical endpoint that the work group will want to take a look at. Thank you.
Thank you, David. And that is correct. We did use the respiratory illness definition. We were hoping to get as large a number of cases as possible. We did look at the other definitions as well, because that paper beautifully lays out the results for the different definitions of respiratory illness used. I wish I could have actually shown all the plots, but that is an excellent point. Thank you.
Dr. Decker.
Just a couple of comments. First, just to remind everybody, when you're trying to look at the influenza-related deaths in this over 65 population, 1% of the U.S. population over 65 dies every year. And so in the face of that, it's hard to separate out influenza-related deaths, particularly with the way people code hospital discharge data and so on. Now, even in this prospective study, 1% of the sample in each group died. And so anything that might be influenza specific is really swamped by those other numbers, which is why it's very hard to detect anything at all for that particular parameter. And then the separate comment following up on the Zurrieta study, I recognize that you've got your rules and that it's observational and it's not laboratory confirmed and so on, but a couple of comments. The first is that this is a major CDC, FDA, CMS study with over 2 million subjects evaluated, and a principal outcome of it was that 22% statistically significant reduction in the rate of hospitalization. To say, well, it's outside of our rules when it's your own study seems a little strange. And the other thing is that you mentioned waiting for the nursing home study, but that's also observational. If you're waiting for that, take a look again at Zurrieta.
I'd be happy to respond to that. There is absolutely no prohibition against using observational studies. We actually would love to see more of them. And in fact, we did use observational data in our last assessment. There was not a lot of it, but it was there, and we actually have a forest plot with I believe 5 observational studies. It was more an issue of trying to walk the balance between what do folks think is the most important outcome. You may be aware that in the past there's been a lot of discussion with influenza vaccine about trying to move towards more specific outcomes, for example, not using serologic data, using sort of hard endpoints like things that are associated with lab-confirmed disease. We definitely do feel it's an important study, which is why we brought it up for discussion, but it didn't quite fit within grade, and had it been graded, probably would have brought the evidence quality down to very low, because we would have had to have downgraded it. We would love to include more observational studies, and we continue to look for them. Thank you.
Any additional question there? And if not, Dr. Grosskopf, could you move on to the proposed recommendations?
I would be happy to. Okay. Thanks for staying with me through all that. This will be shorter. I want to acknowledge some people whose names don't appear on some of the other slides. A lot of these are colleagues at CDC who attend work group calls and are very instrumental in helping me get through all this stuff every 4 months. Thank you very much. Okay, so just to recap what happened in February at our very truncated meeting, we did have already some updated information, policy changes that were approved then. The first was, as is typical in February, we reiterate the core guidance that annual routine influenza vaccination is recommended for all persons aged 6 months and older. That was approved and was signed off on the internal decision memo, as was the revision of the recommendations regarding use of LAIV for healthy children 2 through 8 years of age, in that for the next season, no preference is expressed for LAIV or IIV for any person aged 2 through 49 years for whom either vaccine is otherwise appropriate. So further proposed updates for 2015-2016, of course, as usual, we have an update on the influenza vaccine composition for next season. We do have a couple of strain changes, so that will be mentioned. We also will have updated influenza vaccine product descriptions reflecting any new licensures, labeling information, and expected availability. Some of these things we may not hear about until after this meeting. If they are minor, we tend to include them anyway. But there are some things that we are aware of already that I'll describe on the next slide. And finally, a revised algorithm for determining the number of doses needed for children 6 months through 8 years of age. So with regard to flu vaccine composition, this is primarily for information and not a vote, but to be sure that you're aware, we do have strain changes this year. Our AH1N1 virus will be the same, A California 7 2009, which is an H1N1 PDM09 type virus that's been in the seasonal vaccine since 2010-11. We have a new H3N2, A Switzerland 9715293 replaces A Texas 50 2012-like viruses. And for our B Phuket 3073 2013-like virus, which is a Yamagata lineage virus, we'll be replacing the B Massachusetts 2 2012-like virus, which is also Yamagata lineage, just a different Yamagata lineage virus. For the quadrivalent vaccines, these viruses will be present, plus B Brisbane 60 2008, and that was also the second B virus recommended for last season, so that is not a change. The ones in red are different. Next, we will have information on new licensures and labeling information. You heard from Dr. Robertson and Sanofi Pasteur this morning about Fluzone Intradermal Quadrivalent. All of the intradermal vaccine, we are told, and Dr. Robertson just mentioned, will be quadrivalent next season, so we are mentioning that in the policy note. There is an expanded age indication for Flublok. It's now 18 and older. This was noted previously in the online version of our vaccine table, as well as the ACIP adult schedule, but we'll make sure it's included in this round of our policy note for the fall. There's also the approval of administration of Afluria by the Stratus jet injector for persons aged 18 through 64 years of age. This was also previously noted in the online vaccine table, but will be included in the MMWR coming up. And finally, any additional labeling changes arising prior to publication. We do anticipate minor things. For example, sometimes we find out that some formulations or some presentations of a vaccine are not going to be available, and we will keep up with that through the next couple of months so we have as accurate and up-to-date information as possible reflected. So finally, determination of doses needed for children 6 months through 8 years of age. This is something we seem to visit every year. We have one change this year that the work group would like to propose. Since 2010-11, the algorithm for determining the number of doses for children in this age group has considered the vaccine doses that contain the pandemic 2009 H1N1 virus separately from seasonal antigens. As a pandemic virus, this made sense when it emerged. It was pandemic, considered relatively antigenically novel. However, it did lead to somewhat complicated algorithms, and I say algorithms because for the last several years we've had two, a simple approach and a less simple approach, to try to meet people's needs as best as we could. This virus has been represented now since 2010-11 by a California 7 2009 H1N1-like viruses in the quadrivalent and trivalent seasonal vaccines. There is likely a diminishing number of children each season who have not been exposed to this virus. The work group therefore proposes language that would eliminate separate counting of doses of the AH1N1 PDM09 type virus, and this results in, happily, a somewhat simplified algorithm and only one, should it be accepted. So this algorithm asks first, has the child received 2 or more total doses of trivalent or quadrivalent influenza vaccine during any prior season? The 2 doses do not need to be during the same season. They could have been received during different seasons. They still do need to be administered 4 weeks apart at least. If the answer to that question is yes, 1 dose is needed this season. If the answer to that question is no, 2 doses are needed, or if you don't know. That is the proposed approach for the coming season. And this, to my knowledge, matches what is being proposed by AAP, so there's a good chance that that recommendation will be harmonized if this is acceptable. And that is the end of my talk.
Do we have discussion? I want to just confirm, I saw Dr. Kimberlin nodding yes, so if you're able to confirm from COID.
Algorithm with
Dr. Shukat?
I hate to discuss when everyone's quiet, but would it be possible to cross out trivalent or quadrivalent and just say 2 or more total doses of influenza vaccine? Is that necessary, or?
We had it that way originally. Then it changed to seasonal influenza vaccine, and then some within the work group felt that the term seasonal is somewhat meaningless. What we want to avoid, and the reason that this is there presently, is we want to avoid counting of monovalent 2009 H1N1. It would seem unlikely to happen, but if there were a child that got 1 dose of seasonal and 1 dose of monovalent pandemic vaccine, we would want that child to get 2 doses. But that is something we could do. It would make it less wordy.
Dr. Kemp? Dr. Kimberlin?
I personally kind of like having trivalent or quadrivalent in there simply because people will think about it. You know, the doctors will be sitting there and they'll be thinking, all right, I gave quadrivalent once, I wonder, and trivalent the year before, I wonder if, does that mean they got 2, or this way it addresses it in a pretty succinct way. I wouldn't go to the mat if it was taken out, but I think it's meaningful to have it in there personally.
Thank you.
Any strong feeling amongst the committee members? Apparently not. Dr. Kemp.
Just one clarification. Did you guys discuss whether people would be concerned about this being concurrent seasons? I mean, clarifying that it need not be current seasons, just in terms of you getting questions, I guess. Well, not the same season, but you could have a season in between.
I
You know what
see.
I'm saying?
I see. Okay.
And I gather you're saying that
Yeah.
you're agreeing that should not be a problem.
So you're concerned that it might be interpreted that they would have to have been consecutive doses?
No, I think it's going to be it would be, people would assume it would be, but do you just want to make it so clear that you don't get that question?
We could, for example, say the 2 doses do not need to have been received during the same season or consecutive seasons. Would that work? Okay.
That would be a wonderful, easy change.
Thank you.
So I think the way it stands right now is continuing with the trivalent or quadrivalent, but adding some clarification about the lack of necessity for concurrent seasons. I don't see any additional hands up, so, Dr. Kemp was outcalled.
Yeah, I do think when you read that, and maybe some of these changes we just made will take this away, but it does kind of ask, do 2 doses have to have been received in the same? And really what we're saying is 2 prior doses, whether it was 1 in 1 season and the second other season 2 years later, those count as 2 doses. Okay? So the 2 doses don't have to have been in the same season. And the reason I bring that up is in the past, that was an issue, whether 2 doses were received in the same season or not. I don't think that's entirely clear. Did any of the clarifications just mentioned clarify that?
Yes, and that was the reason for the addition of the footnote. The text also discusses that they don't need to be administered during the same season. I think the addition of the language.
The footnote, I think.
Yeah.
Dr. Belangia.
Okay, so at the risk of wordsmithing, another option would be, has the child previously received 2 or more total doses of trivalent or quadrivalent influenza vaccine, and keep the footnote.
Okay.
Which speaks to what we're getting at. Dr. Hahn.
I'm sorry, this is the wordsmithing, but I'm worried about if you take that word out about prior seasons, a kid could come in who already got flu vaccine that season and still be interpreted as needing more. You know, I just wonder if I think the prior season is important. I wonder if you took out during prior seasons and just took out the word any, because to me the word any kind of seems to make it sound like it's one season you're talking about. If you just said, has a child received 2 or more total doses during prior seasons, is that, I'll give up if I just want to throw that out there.
The more, Dr. Tempty, may I think out loud for a sec? Okay. I think the more I think about it, it seems to make the most clear sense to me to remove the any prior seasons. Has the child previously received 2 or more total doses of trivalent or quadrivalent influenza vaccine, keep the footnote, add in the footnote that they also don't have to be consecutive seasons. That makes sense, I think, at least to my adult brain.
Dr. Lehr?
One small problem with that is that if they got it in September of this year, and they got it last year, but you wanted them to get 2 this year, in October of this year, someone looking at it would say they've gotten 2 already. It's a very fine point, but they might say, I got 1 in September, I got 1 last year, I don't get 1 in October. So,
but if they got 1 in September and then when?
they're due in October. They're supposed to get 1 in September and October. But if you ask this question in October, and you ask that question, have they received 2 previous doses of trivalent, quadrivalent? They got 1 last year, they got 1 in September. Then they're going to, someone looking at this might get confused if you have a different person looking at it.
I think I see what you're saying. So they'd be counting basically across the current upcoming season and last season. One simple fix to that, I think, might be to, in the last 2 boxes where the number of doses are specified, to say 1 dose of 2015-16 influenza vaccine, so we know what we're specifying the current season. And ditto for the 2 doses box.
Okay. Are we, I think I don't see any additional hands up. Do we have someone willing to make a motion here? Dr. Kemp. All right. Second. And Ms. Pellegrini. Any further discussion? Dr. Belangia? Actually, I'll start with Dr. Campos out cold, and let's go to your right. Oh. Yeah, Lisa, are you able to capture all the changes so we have those down?
Yes. I don't know if I can do it on the screen, though, because of lack of a mouse. Okay, so the language would be, has the child previously received 2 or more total doses of quadrivalent or trivalent or quadrivalent influenza vaccine, period. If yes, 1 dose of 2015-2016 influenza vaccine. If no, or don't know, 2 doses of 2015-16 influenza vaccine. The footnote will be amended to say the 2 doses need not have been received during the same season or consecutive seasons.
Further clarification or questions? Dr. Campbell's going to call.
Are we voting just on this question or all previous issues?
That's up to Dr. Tempty.
I believe since the vaccine composition is out of our hands, I believe, and the influenza vaccine product updates I think we can bundle this all together unless there's a reason not to. So the motion is not only for the language change right here on the 6 months through 8, but just to affirm the components and to affirm the product updates. Okay, so I think we have a motion, we have a second, further discussion, and if not, Dr. Campos-Outcolt.
Campos-Outcolt, yes.
I didn't tell you which direction. Sorry about that. Counterclockwise, Art.
Reingold, yes.
Rubin, yes.
Tempty, yes.
Bennett, yes.
Romero, yes.
Riley, yes.
Harriman, yes.
Harrison, yes.
Pellegrini, yes.
Karen, yes.
Belongia, abstain.
Kemp, yes.
Bocchini, yes.
Baskin.
And the motion passes 14 in favor, 1 abstain, and 0 against. Thank you very much.
Thank you
And,
very much.